Hey guys, welcome to yet another lecture. This is a theory lecture over a lab and equipment lecture. This is for Respiratory 2140 and 2160. This is just to cover the theory and therapy of BiPAP, which is bi-level positive airway pressure. Over here, so the difference between BiPAP and CPAP is with BiPAP, there are two pressures as opposed to one continuous pressure. The two pressures are inspiratory positive airway pressure. You'll commonly hear it referred to as IPAP, or sometimes PIP, which is peak inspiratory pressure. This is the pressure used to support inhalation and to reach that top pressure at the peak of inhalation. EPAP is expiratory positive airway pressure. You'll sometimes hear it called EPAP. It can be used interchangeably with CPAP, which is continuous positive airway pressure, and PEEP, which is end expiratory pressure, which is pressure used at the end of exhalation to help stent airways open. Here is a diagram to explain IPAP and EPAP. So as you can see on the bottom, we have our EPAP. This supports oxygenation. We can increase EPAP to help increase our oxygenation. This occurs through alveolar recruitment. By increasing EPAP, we help open up those alveoli, and positive gas exchange occurs when we have an increase in pressure and an increase in surface area. So EPAP, oxygenation, associate those two. IPAP is the pressure we use to support inhalation. So think ventilation. I also like to refer to it as a loose term of tidal volume. So by increasing our IPAP, we increase our tidal volume, which is the volume of one breath, one inhalation and one exhalation. So by increasing our IPAP, we increase, as you can see that little triangle and that little P, that is called we sometimes refer that to the delta P, or the change in pressure. That change in pressure is what affects our CO2 or our ventilation management. So by increasing our IPAP, we can decrease our CO2 by increasing ventilation or increasing one volume of air or one breath. If we, for some reason, are blowing off too much CO2 for our patient or providing too much volume, we can come down on our IPAP to help our CO2 increase, which would decrease that change in pressure. So the change in pressure is the difference between the inspiratory pressure and the expiratory pressure. If you guys get a little confused, some people will refer to this as their pressure support. So if you hear that, sometimes people use that interchangeably with the delta P. So when you're managing your BiPAP, we'll start with the top one. So up here is a reference diagram of how changing IPAP works. So at the bottom, we can see a continuous EPAP. And this first breath over here is one breath. So we needed to increase our volume for our patient to blow off more CO2. So that's what we did right here. We increased our IPAP, which changed our delta P. So that difference right there is our increase in pressure, which is our increase in volume, which helps increase our delta P, or our volume, to blow off more CO2. That's how changing the IPAP affects ventilation. If we come down here, we can see how EPAP changes. This one can get a little bit tricky. So if we change our EPAP, so at the far left here, we can see this is one breath we're delivering with our delta P. By increasing our EPAP, that helps increase our oxygenation and aids in alveolar recruitment. So if we have a patient with atelectasis, for example. But if we just change our EPAP, but not our IPAP, we would change our delta P, or our change in pressure. So if you increase your EPAP, you need to change your IPAP the same distance if you are happy with ventilation. For example, let's say I have a patient with an EPAP of 8 and I increase it to 10. So I change it by 2. Let's say the IPAP originally was 10. But I'm happy with the volumes and the ventilation that's occurring. I would increase that IPAP of 10 to an IPAP of 12 so that I could maintain the same ventilation but improve my oxygenation. You can use this also if you need to change both. Say we need to increase our oxygenation. We could increase, say, our EPAP by 2, so we'll use the same. We're increasing from 8 to 10. So we go from an EPAP of 8 to an EPAP of 10. But let's say our ventilation's not great. We can also increase that. So let's say we have an IPAP of 12. Instead of increasing it by 2, we want to increase our volume. So let's say we want to increase it by 4 so that we can improve both our oxygenation and our ventilation. So our IPAP of 12, we would increase to an IPAP of 16. So we would change it by 4 to aid both oxygenation and ventilation. So just be careful. I like to think of it as a shape that I need to move consistently. So this shape, I needed to move just up 1, but I wanted it to maintain the same size. So that's how EPAP and IPAP can work they work independently of each other. So just keep that in mind. And this is with BiPAP. When we get into mechanical ventilation, some of the machines will compensate for the different changes, but with BiPAP, be conscientious of how the IPAP and the EPAP work independently of each other. Okay, over here, I personally, when I was learning oxygenation and ventilation and the differences, I liked to separate what affects my ventilation and what affects my oxygenation. It helps keep it simple. It helps keep things clear in my head. So if I need to adjust my CO2 or my ventilation, I will either adjust my respiratory rate or my IPAP. If I need to adjust and this is because those two affect volume. If I need to adjust my oxygenation, I will either adjust my EPAP or my FiO2. So we will either use to improve oxygenation pressure or chemical, or our drug, which is our FiO2. So with rate, you can set a rate on BiPAP, which is the number of breaths delivered in 1 minute. One requirement to be on a non-invasive BiPAP is the patient must be spontaneously breathing, otherwise they need to be intubated in order to support an adequate respiratory rate to keep your patient alive. So this is the total number of breaths delivered in 1 minute. The patient, every spontaneous breath, you will deliver the same IPAP, but I use the set respiratory rate. I typically keep it lower so that the patient doesn't find it uncomfortable. I like to start at a rate of 10 for a patient on a BiPAP. So then I like to treat the respiratory rate as a recruitment breath or as a reminder, as opposed to actually providing ventilation for them. So that is the most important thing. A patient must be spontaneously breathing and use the rate more for recruitment and as a reminder over actually supporting your patient's spontaneous ventilation with BiPAP. One thing you guys will see is I time and rise or flow. As with respiratory therapy, anything can have about 3 different names. So with rise, this is the flow setting we deliver during inhalation. And as you can see, we have on these diagrams, up here, we see the IPAP. Both of these diagrams have the same IPAP. But as you can see, it takes longer to deliver that breath up to reach our IPAP, as opposed to this one, which is a short delivery to IPAP, our IPAP. This can be set with iTime depending on the machine you're using. So a lot of the machines I use IPAP, and they also use this rise feature. So both of those are used to determine iTime is the inspiratory time. It's the length of time to go from one point of exhalation to inhalation. While flow is how much air, or I like to use the term aggressive, I feel like is a simpler way, we deliver that breath. The analogy I use is, so you guys all have heard of my dog Artie. With eye time, let's say I'm taking Artie for a ride in the car and I roll the window down while she has her seatbelt on. So if she sticks her head out the window for the same amount of time, so let's say for 1 second, she sticks her head out the window, but that will be eye time. So she sticks her head out the window for 1 second each time. The flow will be how much air is going. So if I am going 15 miles an hour and she sticks her head out for 1 second, or if I'm going 60 miles an hour. See how it's the same amount of time, but the amount of air or flow delivered is differently and more aggressive? That's the relationship between eye time and flow, or rise. Times you would adjust rise would be for comfort. Patient comfort is huge when it comes to flow, eye time, rise, any of those. But therapeutically, you can adjust it by giving a longer rise, aids with alveolar recruitment. We have that higher pressure for a longer period of time, which helps us with oxygenation. This also helps with patients with restrictive disorders. A shorter rise time allows for longer time to exhale, which aids in a longer exhalation. It allows more time for CO2 to be blown off and is commonly used for obstructive disorders, such as asthma or COPD exacerbations. You guys will hear me talk a lot in 2160 about how COPD patients love BiPAP. This is a time you would strategize to help those COPD patients with supporting their ventilation, getting CO2 off, and pressure. Obstructive disorders just love pressure. The lungs and the patient respond very well. So moving on, we're going to talk initial settings. So the initial settings for BiPAP, again, it's all patient dependent. So a typical respiratory rate would be between 10 to 20 breaths per minute. Adjust per your patient. If they're sleepy, you might need to go up a little bit to maybe 15. If your patient is tachypnic, a little bit lower at 10 might be more comfortable for them because they're supporting their own respiratory rate. An IPAP of 8 to 20 centimeters of water pressure is most common. And again, that depends on what is happening with your patient and the return volumes you're getting from your patient. So you'll be able to see exhaled volumes on the BiPAP, and you'll see that on my V60 video. Based on exhaled volumes, you can adjust the IPAP up and down. EPAP, 5 to 6 centimeters of water pressure is a typical starting point. A pressure of 10 centimeters of water pressure or greater is considered therapeutic, which is to aid in therapeutic means to aid in alveolar recruitment. FiO2, you can either put it on what the patient was previously on, titrate to support SpO2 and PaO2, or 100% for emergencies. Rise, I typically will set it to the middle and then adjust per my patient's comfort and needs. So some indications why we would place a patient on BiPAP would be acute respiratory failure. This is becoming very common to treat patients non-invasively over just automatically knee-jerk reaction going to intubation. Because if we can avoid an intubation, then that is a success for that patient. It decreases trauma, it decreases infection, and just any risk to the patient that comes from intubation, such as hypoxia or trauma to the airway. DNI orders, if you have a patient in respiratory distress that does not want to be intubated, but you can support their ventilation, BiPAP's a great option. I like to think of BiPAP as the Band-Aid of respiratory therapy. We are trying to cover up the gaping wound that is respiratory failure and trying to get them to a point where they are stable using non-invasive methods. So I am a huge advocate for BiPAP. It can be well tolerated. A lot of patients will find the mask a problem. Some patients have claustrophobia issues. So that is something to keep in mind, is claustrophobia. But BiPAP does a lot of good work. It helps a lot of patients, and I am a huge advocate for it. You can also administer medications through it, and I will show you all that when I show you the V60 video. Be sure to write down notes, bring it to lab, bring it to class, and this will just be used to help you with your home study. This is just an introduction to BiPAP. We'll go over scenarios together in class. So thanks, guys, and we'll see you in class.